pleasure and honor to introduce my colleagues, Professor Umesh. He is a professor of radiation oncology from India, and his lecture will be on CT-based contouring and image-guided brachytherapy for cervical cancers. Please, Dr. Umesh.
Thank you, chairpersons, for that kind introduction, and thank you very much, the organizers, for inviting me again. I'm lucky enough to travel to Egypt twice within a month's time, and it's always a pleasure to be here in Egypt, because Egypt is one of the countries where I see changes happening on a very rapid scale, and I think that is a good news, and it motivates me to come again and again. Thank you very much for these developments, sharing these developments with me. So this is part of the workshop, but what I will do is I will give you some theory background for why we ventured into CT-based contouring. Before that, I have a couple of messages which might help you to refine your treatment protocols further. This is a slide which shows now the planning aim or the prescription which you have to define the moment you see a patient in your clinic who has been referred by gynecologist or medical oncologist for radical radiation therapy for cervical cancer. And this includes chemoradiation, which chemo to be given, what are the radiation details. You have to decide upfront. That's day one of your planning. External beam, brachytherapy. In external beam, you have to find out whether you want to go for a high-end technique like IGABT, whether you want to go for simultaneous integrated boost if there are large nodes. Then brachytherapy, and I put fractionated HDR because 90% of the world now is more or less doing high-dose rate brachytherapy. There are only a handful of centers who are still doing PDR. There was a question about a lot of experience of LDR in this country. Believe me, this fractionation, 7 gray into 4 fractions to point A planning aim, is more or less equivalent to what LDR doses you have been delivering for many, many years. And that we have proven in a randomized trial which has been published from Tata Memorial Hospital recently. And if you wish to have that full article, please let me know. I will pass on to you. And that trial has shown that there is no difference in outcomes in terms of local control rates as well as toxicities. So suffice to say that this is more or less equivalent protocol which you can easily adopt. So the last most important part of the prescription is that you have to define upfront what are the doses to various organs at risk you are planning for these patients when you start external beam radiation therapy. This is second important slide which you discussed in detail earlier, that overall treatment time is a very, very important prognostic factor for cervical cancer patients, and the overall treatment time as low as possible is better. And I have shown here an example of 8 weeks, but believe me, our EMBRACE research now says that the overall treatment time, if it is less than 42 days, it is better in outcomes. So it's suffice to say that you have to squeeze in the chemoradiation protocol very efficiently, support them whenever they have reactions, side effects, so that the treatment is completed within 6 to 7 weeks. And second most important message from this slide is that please plan your brachytherapy towards the end of external radiation. Historically, we also at Tata Memorial Center, we integrated brachytherapy very early in the treatment of cervical cancer, as early as second week of external beam radiation. But now the research suggests that you shrink the tumor optimally by 4th to 5th week and start your brachytherapy in 4th to 5th week onwards. So what it means is you're targeting a lower volume with a very high doses of brachytherapy, and that itself improves the outcome to a large extent without going into various developments which you have seen now. So there are some schedules. I will not go into the details because this is not the topic of discussion. This is just to show how you can achieve the oral treatment time of 6 to 7 weeks. There was a question as to patients are referred after external beam, after 1 month, 2 months. What you could do is maybe shrink that brachytherapy fractionation schedule within 2 to 3 days or 1 week's time and finish the entire brachytherapy by delivering a fractionated HDR brachy schedule. And we do that routinely because that is also very common in India. In fact, there is a protocol which I have published recently now where only one application 3 treatments and treatment is over. But the treatment is for 2 days. Patient stays back in the hospital for 2 days. But what is important is you put in lot of efforts for the first application, put in lot of efforts for brachytherapy planning. If you achieve excellent constraints, treatment is finished in 3 fractions, which is delivered over a period of 1.5 days. And that is quite attractive. We have shown that it is safe and it is not compromising any outcome currently. So that protocol has been published, so you could utilize that to shrink your overall treatment time as well. This is a busy slide. On the what it shows is various processes involved in brachytherapy for cervical cancer, and for that matter, it is applicable for any brachytherapy procedure you see. On the left side is what you have been doing conventionally in an orthogonal based planning or a 2D. On the right side is what is the latest update of 3D image guided adaptive brachytherapy. The first message is that all the processes you have been doing earlier also, and the same processes continue in 3D. So the number of processes, whether you did X-ray based or CT based or MRI based, number of processes doesn't change, except that now because of cross-sectional imaging, CT and MR, you contour target volumes, you contour organs at risk, which you have been doing for decades for external beam. So that's the only advantage. And second advantage is that the medical physicists are in a better position now to optimize the treatment plans, because by virtue of defining the target, by virtue of defining the organs at risk as a volume parameter. The next important message is that all brachytherapy procedures should be done under some sort of anesthesia. If you think that anesthesia is very expensive, believe me, it is worth that expenses, because the advantages outweigh whatever you are trying to reduce the cost. And that advantage is that you can get an optimal implantation technique. Vaginal packing is adequate because vaginal muscles are relaxed. If packing is good, organ at risk doses can be reduced efficiently. So if you are able to do that, your therapeutic ratio obviously increases. If your therapeutic ratio increases, the outcome is better in terms of disease as well as toxicity. So obviously the quality of life and cost is going to be reduced to the patient. Next 2-3 slides are basics which you have been well versed when you are doing conventional brachy. This is a standard pear-shaped distribution when you load into the tandem and the ovoids. And once you define a point A, you prescribe the dose to point A, that is 100%. What is important for you to realize here in this pear-shaped distribution is, at the level of point A, you know it is 2 centimeters on the both sides. So 4 centimeter width is treated at the level of point A. If you come 1 centimeter below, you land up treating roughly around 2.5 to 3 centimeters on either side. So it is around 5 centimeters. At the level of ovoids or rings, it is roughly around 3 centimeters on both the sides. So you have 3 centimeters width from the tandem. At the level of ovoids, 2.5 to 3 centimeters, 1 centimeter above, and at point A, 2 centimeters. So you have that range of width which is treated with a very nice dose when you do intracavitary brachytherapy. If you are able to understand this concept when you are doing brachytherapy application, then you're master of image guided adaptive brachytherapy by 50%. Okay, so and that I will tell you how you can achieve. So these are common clinical scenarios you see in your routine clinical practice. On the first left half side is residual disease confined to cervix or just medial parametrium. Is very common finding, especially when patients have 1B, 2 and 2B. After external beam and chemo, usually you find this scenario. The second category and third category are patients who are more advanced at diagnosis and have responded partially after chemoradiation. So what it means is, the pear-shaped distribution, if you see, is covering adequately your category 1, where patients have minimal residual disease in the cervix and medial parametrium. The moment the parametrial disease starts extending more laterally, then the pear-shaped distribution is suboptimal. So it means you will land up suboptimal doses to the target volume clinically. Of course, this we are going to do exercises. Now we are fortunate enough that we have now latest applicators which are available, and these are various applicators shown here. I'm sure you'll have a more demo about these applicators very soon. Coming to the imaging modality which is used for contouring, these are the various imaging modalities which have been tested, and what I have highlighted in blue is what is very vital for low middle income countries, because MR, although it's a gold standard, is not available widely, not only in developing countries but also in developed countries. It is not very easily available. So clinical examination and 3D mapping, you are rich in that because you see patients day in, day out. CT imaging, easily available in most of the departments because you are doing external beam with CT. And last, cost-effective modality is the ultrasound. And I was very happy to see an ultrasound, portable ultrasound unit in one of the units here. It helps a lot if you have an ultrasound in your brachytherapy suite, and that investment is very, very cost effective in treating patients of cervical cancer with brachytherapy. And that ultrasound utilization itself reduces the morbidity by 25% in your routine practice. How? 15% of the times you will spare perforation of uterine cavity when you do ultrasound during brachytherapy procedure, and the remaining 10% comes from when you combine with CT imaging and do an efficient contouring for organs at risk as well as the target. As I said, you are very rich in the experience of clinical examination. This is a clinical drawing which was adopted by Embrace Research Group from Europe, which captured various parts of disease on various sections, axial, coronal, sagittal, as well as colposcopic view. And what it also showed was which component of disease responds. If you are able to clinically examine every, let's say every 3 weeks, you are able to understand which component of the disease, whether it is primary tumor, vaginal disease, or parametrial disease, which is shrinking. So this documentation becomes very objective. So if you are on leave and if colleague wants to check what has happened to the tumor, these clinical drawings help become handy for that person to find out what has happened as of today when they examine. This is only a summary slide which says that the gold standard imaging for cervical cancer is MRI, whether it is at diagnosis or whether it is at brachytherapy, and in the today's era, image guided adaptive brachytherapy. And most of the recommendations which have come for brachytherapy for cervical cancer have been based on MRI. And the reason is obvious. You can see that the disease is seen very nicely on a T2 weighted image. Axial, sagittal, and coronal is shown in an example here. And since you can identify the residual disease or the disease at the primary, it is very easy to come up with a target concept and organs at risk, so that you can implement image guided adaptive brachytherapy. And this is the basis for the latest ICRU report, the ICRU 89, and I'm sure many of you have a full copy of this. ICRU 89 is a document which really goes into lot of details, including historical aspects of brachytherapy for cervical cancer. But the highlight of this is that we have all the chapters which deal with various processes which I showed of a brachytherapy, and each process is dealt into detail in the form of a chapter for every process for brachytherapy. So I would strongly recommend you all to read at least once. And for students, there is no excuse. You have to go through the full entire report, which is roughly around 270 pages. Coming to topic of my presentation, CT obviously is more attractive because it is easily available, and most of the surveys say that CT is very easily available for contouring. What we did was, when we realized that CT is more of a necessity for us in our country, so we did a lot of testing with the use of CT. And we tested the use of CT in various settings. First one was incorporating CT imaging for routine brachytherapy planning. And I'm happy to see that one of the example had this routine brachytherapy planning with intracavitary standard pear-shaped distribution without a target concept. Second was, we also utilized CT for modifying our brachytherapy technique after first application. And that helped a lot to really optimize the brachytherapy application as well as the doses. And the third concept was, we came up with a target concept. So I will not go into all the three details, but I will go into some theory of CT based target concept. And the prerequisites, of course, are that you need to understand the concepts from MRI and the clinical examination. Then you also need to sit with your radiologist to find out what CT anatomy you need to know so that you can contour a target on CT. And most important is you will have to go for a CT MR compatible applicators because that throws less artifacts, and that is shown in this picture here. High density materials should not be used because it throws a lot of artifacts, so you will not be able to see the target. If you are not able to see the target, you will not be able to contour anything as a target. So with this background, over a period of 2 to 3 years, we worked on some recommendations, and we were fortunate enough. The Indian Brachytherapy Society, the JEC, ESTRO, and ABS came together for these recommendations, and all the experts came from various parts of the world. And I have somebody from here as well. I think Niyamat and Sandy Mohammed are from Egypt. They were kind enough to be part of these guidelines, and this was based on various publications which were available with the CT for different processes which I showed. So based on that, we came up with these recommendations, and if you go into details, these are the 4 sections, and believe me, to understand this, you will at least need to read it 2 or 3 times minimum. And also very important is, please do not forget to read the appendices. Appendices has also a lot of material which is helpful for your understanding. So we classified into 4 sections. The first highlight of first section is this clinical drawing which we modified from the Embrace group. And the modification was, we defined a new concept called as near maximum distance. And what is it? It is nothing but the width which you examine, the width of the tumor which you examine clinically was subdivided into right and left. And this right and left division was based on where the central tandem would be, where the uterine canal would be. So when we examine, we always now document the right near maximum distance and the left near maximum distance in relation to the cervical canal or the uterocervical canal. And this helps a lot to understand how asymmetric the disease is at diagnosis, and if you repeat the examination at the time of brachytherapy, again how good the response is, whether the response is symmetrical, asymmetrical, what is the width on right side, what is the width on left side. That helps a lot in understanding what should be done for these patients. So these are advantages if you start documenting near maximum distance. First, it will help you understand the response and categorize them into 1, 2, 3. The next important step is, it will help you to select which applicator is which applicator is suitable for that brachy application, whether you need to push needles. And last but not the least is, if you start documenting near maximum distance, inter-institutional comparison becomes very objective, and it will help you to collate the data and come up with some concrete outcome data in terms of NMDs. The next important part is defining and setting up a CT protocol, and this is an example here shown. Obviously, you have to use CT compatible applicators. Next important step is bladder filling protocol, and if you can appreciate in these pictures here, we have pushed 20 ml of contrast into the bladder cavity, not in the Foley's bulb, into the bladder cavity, which is mixed with 1 ml of contrast with 20 ml of saline. And you see how nicely the bladder is delineated, especially the posterior wall. If you are able to do that, then your contouring of posterior wall becomes very easy and convenient. If you are able to do that, half of your problems in brachytherapy planning will be reduced, because you are actually documenting what dose is going to the bladder volume. Otherwise, if there is no contrast, all looks gray, everything looks gray, and if everything looks gray, everything looks like bladder, and then you will land up with a geographical miss of the tumor. On similar lines, you could also do it for rectum and sigmoid. The last most important step is, like external beam radiation, always push an IV contrast, because there are certain anatomical structures which is very vital to define the target volume, which I will discuss during the contouring session. The last important modality is ultrasound, and here I have shown transrectal ultrasound is really a big area of research now for cervical cancer brachytherapy. A lot of developments happening now in this imaging modality because of the easy availability, and second, if you are able to procure a transrectal ultrasound, there's an image which shows after I put a tandem, I do a transrectal ultrasound, and on transrectal ultrasound, I am able to now measure the near maximum distance on ultrasound, and if I am able to measure that distance, I extrapolate that on a CT scan with the help of measurements, and a contouring is more efficient on CT. So combination of transrectal ultrasound and CT really works very well, and I will give an example of that. There is a learning curve with the use of ultrasound, but it takes maybe 10-15 patients, and it is always important to call the radiologist for a couple of times to find out how you can utilize this imaging modality, which is very easily available now. And it costs only additional few lakh Indian rupees to augment your portable ultrasound for transrectal ultrasound probe. And we did this study where we compared transrectal ultrasound on CT versus MRI, and we have shown that more or less the target volume in terms of width as well as the height is similar to if we had to do an ultrasound. So many a times we use this now in the routine clinic. This is just a workflow of one of the patients where we have MRI diagnosis, we have clinical drawing. At the time of brachytherapy, we again document the clinical drawings, the near maximum distance, and the transrectal ultrasound images taken at various levels. And with the help of those measurements, we then contour on CT and optimize the doses on CT, and that works very well. The second section is, as I said, classifying the patient into various response categories, because this helps you to identify what brachy application can be done for various categories. And I've shown in red the category 2 and 3 because these are more common in more locally advanced disease, where chemoradiation results in a partial response, and you always have some induration in the parametrial tissues. Oh. Can I have a couple of minutes more? Yeah. Thank you. So the third section is, in these recommendations is, we have defined the environment, because there are various different environments. Some may have CT at diagnosis, and then you have CT at brachytherapy. Some may have MR at diagnosis, and then CT at brachytherapy. These two scenarios are very common in India, and I'm sure it is also here, because gynecologists invariably ask for MRI at diagnosis because they are always eager to operate these patients. So they need MRI pelvis. So if they have advanced disease, then this MRI becomes quite useful and handy. So the fourth section, we have defined how to define a target on these various scenarios. I will not go into the details, but I will show only the pictures because of shortage of time. So this is an example of a picture, a clinical figure for CT-based high-risk CTV definition in different environments. So the left upper corner is CT at diagnosis, CT at brachy. The second upper corner is MR at diagnosis and CT at brachy. Third one is CT at diagnosis, and you have an option to do a pre-brachy MRI in a radiology department, which is in a MRI center where it is not in your hospital, and then you do CT at brachy, and the last is MR at diagnosis and pre-brachy MRI. But the commonest scenarios are at first and second for us. So for each environment, then now we have defined how you can contour width, height and thickness. In terms of width, lateral, in laterality on both the parametrium, in height, how you can efficiently contour in the superior and inferior extent, and in thickness, anterior and posterior. Just to give an example here, this is MR at diagnosis and CT at brachy. The upper cartoon is at diagnosis. So it's a, let's say, a stage 2 disease. And depending on the category of response, now the red color shows the high risk CTV. So if the category of response is 1, it means there is no disease in the parametrium. There is a more or less complete response or residual disease only in the cervix. So your high risk CTV is only cervix. And here, if you carefully see the arrow shown from the lower extent of disease to the fundus is what we measure at diagnosis. And if that measurement is there, at brachytherapy, the same measurement is used to efficiently contour the superior extent of the high risk CTV. If there is no transrectal ultrasound image, then your estimation is slightly more, so you can give more margins in the form of 3 to 5 millimeters so that you don't land up with underestimation of target volume. I will not go into the details because this is going to be discussed in your workshop. So on similar lines, if you see CT at diagnosis and CT at the brachytherapy, the major limitation, if you do not have MRI, is what is happening to the tumor which is extending into the uterus is not seen on CT scan. That is where you are blind. You don't know what is happening. That is why MRI scores over CT in this scenario. So what we have done is, if you do not have MRI diagnosis, depending on the category, the width thickness remains the same, but if you see height, we have overestimated the height. So what we do is, we take the lower 2/3 of the uterocervical canal as the height of the high-risk CTV. And this comes from a publication from Vienna, which suggests that if you are including 2/3 of uterocervical canal, 96% of the times you do not miss anything. So this is the so these recommendations are purely based on the publications for various aspects what we have mentioned here. So with this, I would like to just highlight that these are all recommendations which came up last year. Now we are in the process of floating a prospective registration study where we are going to test these concepts in a prospective study, and this will be open for this will be activated very soon, maybe by March, April this year, where international centers, including from Egypt, are welcome to join this program. Yeah, this is, I don't want to go into details. So this is a summary that you definitely need to understand the concept from MRI, and you need to standardize the CT protocol, and then with the help of ultrasound, if possible, you can come up with a target concept on CT. And these are various publications. If you want to go into details of these processes, you have these publication. This is Indian Brachytherapy Society publication, where a lot of processes which are required for brachytherapy have been gone into detail with the scientific background. Last important message, now we have come up with something called as Brachyterra, and this is a venture which we have started recently. This is a non-profit learning platform where you will be given a free access, and here most of the teachers from Europe, from Indian Brachytherapy Society, have come up together to come up with an online training module for brachytherapy, and the main emphasis will be for low middle income countries where MRI is not available. And what we have done here so far is that we have started a Sri Lankan course, online course. Then we have also started now Indian Brachytherapy Society course, workshop, and then we are also going to integrate this platform for training everybody around how to do CT-based brachytherapy contouring as well as planning. So I'm happy to invite you all, not only from Egypt but other African countries. If you wish to join this platform, or if you wish to develop a course online free for all your colleagues, please contact us, and we'll be more than happy to develop one course for this region. Thank you. Sorry for the additional time.
No problem. Thank you, Professor Umesh, for your excellent and informative presentation. Now we will go for a live discussion with questions and answer. It will be moderated by